Everyone, welcome to our third session for the first stage emergency workshops. If you did miss the first two, they're uploaded onto our YouTube channel, which is Dnipro Medical Institute SU, so you can watch them there. So the aim of these really is just to give you guys knowledge on different first aid emergencies that you may encounter and how best to deal with them as like a first line. This is, just to disclaim, this isn't a certified course, but we have done our research and we've got trained and experienced people teaching the sessions. So for today's session, we have Paul and Jean-Pierre, who will be teaching allergic reactions, diabetic emergencies, poisoning and asthma attack. So over to you guys.
Okay. Hey, all right, guys. I'm Paul. This is JP.
Jean-Pierre.
I am fourth year medical student and
Sixth year medical student.
yeah. Okay, so he knows all the stuff.
Well, he's done
I'm just
this.
here to make up the numbers. So, you want to go first?
Yeah, I'm going to be going first with diabetic emergencies. So I've got a presentation to show you what diabetic emergencies look like. So, diabetes. So what I want to cover during this is a background of what diabetes is for those that might not know. Then talking about hyperosmolar non-ketonic states, which is the most dangerous. Then diabetic ketoacidosis, then hypoglycemia. So these are the emergencies that you might confront being on placement or even in the general public. Being a medical student, the first actions that you should do in these situations. So just going to use an illustration that I usually use in placements when talking to patients about how diabetes works. So for this example, the door will be the cell membrane. The wine gums will be glucose and insulin is the key. So what I usually say is that insulin is the key to open the door to your cells to let the glucose in. So talking about a normal situation, your insulin will go to the door, open said door, allowing the wine gums to come inside. But with diabetes, as you probably are aware, type 2 is an insensitivity to insulin. So you'll have more insulin having to go to the cell membrane to allow the glucose to pass through. So this is the stage 1 in diabetes. You have a higher insulin within the patient's blood, but they won't have hypoglycemia. As you can see in the second diagram, the door has now become so insensitive and changed that you're going to need 3 keys to open the door. And in this illustration, you'll see that despite the fact that you have enough insulin to open the door, it's taken so long that you will have a buildup of glucose within your blood, which will give you hypoglycemia. So this is just the mechanism in which type 2 works in stage 2. If you look in stage 3 diabetes with type 2, nothing's going to open that door. That's the point I'm trying to illustrate. There's no key in the world that will open said door. So what you will have is this happen. Severe hypoglycemia. This is type 1 diabetes. There's nothing wrong with the slide. This is how it looks. There is no key. There is no insulin. So as a result of there being no insulin, you will have this happen. Severe hypoglycemia. Unless you give this patient artificial insulin, they will not be able to get the glucose into their cells. So just going through the points illustrated from those slides. So it's a group of disorders characterized by a relative, in the case of type 2, or an absolute deficiency in insulin secretion. And this leads to a state of chronic hypoglycemia, disturbed metabolism of carbohydrates, fat, and proteins, and the development of chronic complications. So the chronic complications that we won't cover in detail would be diabetic nephropathy, where it will affect your kidneys, causing glomerulonephritis. You will have retinopathy as well, and you will have neuropathies as well, where you will start feeling, you have reduced sensation, which is why one of the biggest problems with diabetics is diabetic foot, because they don't feel pain in their foot. So when they have ulcers, they become gangrenous, and that's why they have to get their feet amputated, and things amputated quite a lot of the time. So going through now the first emergency, hyperosmolar non-ketonic state, HONK. as it's more commonly known. So this only affects type 2 diabetics, which I will explain why in the next slide. But the mortality rate from this is 20 to 40%, much higher than diabetic ketoacidosis. The things that you will look for will be the plasma osmolarity will be greater than 340, where the normal range will be 275 to 295 osmoles per kilogram. And the glucose will be over 30 millimoles, and that's during fasting or any state. The normal fasting glucose will be 3.5 to 6 millimoles per liter. So it's a state in which your blood is basically just it's hyperosmolar, it's really thick, and it's extremely dangerous for the patient. So the reason why it is that way is because if you look on this diagram, unlike in a normal scenario where you will have high blood glucose and then you'll switch in the normal diabetic ketoacidosis to making ketone bodies, you don't do that in this. So you will just have this cycle continuing, and you're just going to continue to make more glucose, and your blood's going to become thicker, which is why you become extremely dehydrated, which is why your thick blood will have an increased risk of MIs, DVTs, pulmonary embolisms as a result, and acute renal failure as well. So extremely dangerous. And now we're just going to cover what you can do in this situation. Triggers. So you'll usually have the patient coming in after having a lot of fizzy drinks recently. They're not taking their medication at the right time or it's ineffective. With diabetics as well, they can have episodes of hypoglycemia when they're in a state of like infection or fever. It just causes the glucose to go naturally up, so the insulin they're taking will be insufficient for that. Having diabetes and taking a diuretic or waterfall for high blood pressure will also help to cause that as well. Not checking your blood sugar regularly, just basically the same as the second point. So just not being aware of how to take the medication or just checking your blood sugar levels as well. And drugs and alcohol, because they will also stop gluconeogenesis and will all promote it, and that will just help the state happen as well. So these are the triggers that you should look out for in patients when you're taking your history. Clinical features, the first thing that you will see is thirst, so polydipsia. So the patient will present extremely thirsty, and that should be your first wake-up call to he might be suffering from HONC. Then polyuria, vomiting, you'll see later on, confusion, decreased consciousness, and they might have neurological symptoms that will mimic a stroke, like weakness on one side, and and from embolisms as well, but you'll see that happening a lot later on in the history of the patient. So your management as a medical student is to call an ambulance, because you cannot manage the situation. Because to do it, you would need to slowly give them insulin and also dextrose and corticosteroids as well, using the sliding scale, but you won't be able to do that, especially in an outside setting. So the best thing you can do is call the ambulance straight away, relay that you think that this person has suffered from HONC, and if you have fluids on you, give them as much fluid as possible, because remember, they're hyperosmolar, so you want to dilute their blood as much as possible. So the more common one that most of you probably heard of is diabetic ketoacidosis, commonly known as DKA. So this only affects type 1 diabetic, so no insulin at all, and the mortality rate is less than 5%, so a lot better than the previous one. This is, you diagnose it as glucose being over 11 millimoles per liter, much lower than the 30 millimoles per liter for HONC, and you have blood ketones, which will be greater than 3 millimoles per liter as well, or ketonuria, either one can be used. And yes, so as you can see, ketones are the key factor within diabetic ketoacidosis, which will explain some of the different symptoms that you will see with these patients as well. So triggers, similar to diabetic, to HONC. So infections, like I said previously, they can cause you to be in states of hypoglycemia naturally, so your dosage for insulin will be less than required, so that can lead to the state. Alcohol abuse, similarly with HONC, will cause you to go into this state more easily. Missing an insulin dosage as well can cause it, obviously. And myocardial infarction as well can also cause you to be more prone to get into this state as well. So these are just some triggers in the patient's history that you should look out for when thinking about DKA. Clinical features, dehydration, which will then lead to tachycardia, hypotension, postural hypertension as well, and then can eventually lead to hypovolemic shock. The key characteristics that you'll see in questions and with patients is that they'll have an acetone or pear drop breath to their smell to their breath, which is just a sweet smelling breath, which is characteristic of DKA. And then Cushmal breathing, which is increased respiration, which is a compensation for the acidosis. So they're trying to increase their respiratory rate to get rid of as much carbon dioxide as possible to try and lower their increase their pH. Because at this moment in time, because they're acidotic, by releasing more CO2, it's the way to try and get their pH back to the normal level and decrease the level of consciousness from normal to drowsy to coma eventually. Management, you can't handle this still, so you call the ambulance and you try to hydrate them as much as possible and get them to the hospital as quickly as possible. Hypoglycemia, which is a lot more difficult but a lot less deadly, is because it's difficult because even though, like it says on the screen, it's diagnosed as having less than 2.5 millimoles per liter, but as the third point illustrates, many people don't show symptoms because a lot of people that are diabetics, they go through hypos all the time. So their first hypo, they'll really feel it, but then subsequently they can ignore the symptoms and they won't know they're going into a hypo. So the triggers, so has it happened before? Is it frequent? Their blood sugars over the last few days, have they been missing their insulin dosages? And most commonly, is it accidental or is it deliberate? Because some people sometimes do this deliberately as a way to try and commit suicide. So it's always good to risk assess these whenever you have the situation. So we're going to go through the clinical features, which are 4 types. So the key point is that early recognition is the prevention for emergency cases in this. So the early recognition clinical features are the sympathetic stimulation. Then after that, which is the thing that the classification of clinical features that you don't want to get to, is the neuroglycopenic stage. Then you have the hypoglycemic unawareness, and then finally the rebound effect, which is when it happens in sleep. So the ones that you want to look out for being a medical student should be the increased heart rate, the sweating, the tremor, and the anxiety. So this is for the sympathetic stimulation phase. So this is the one where you look out for to stop them from progressing to the other one and quickly solving it before more damage is done. Then you have the more serious phase where there can be long-lasting damage, which is the neuroglycopenic stage. So poor concentration, confusion, slurred speech. Don't mistake them for being drunk, which can happen commonly. Personality change, so aggression is the most common one. Seizures, eventually a coma. Upgoing implantus just basically means that their feet, instead of being like this, they're like this. So they're just going to be fixed in that position. And the result is a more gradual, this results from a more gradual decline in blood glucose, and it's unusual unless it's less than 2.2. The one that we were talking about previously was patients with long-standing diabetes can lose the ability to tell if they're in hypos. So they skip the neuroglycopenic stage and they go straight. Sorry, they skip the sympathetic stage and go straight to the neuroglycopenic stage. So that's what you need to really watch out for, patients that can just go straight to the second stage. And then lastly, which is what I've seen most commonly, is the rebound effect stage, the nocturnal hypos. So they're often slept through and they just wake up feeling very tired with headaches, almost feeling like they're in a hangover. And that's usually because they've taken their insulin way too late at night. So they've put themselves into a hypo while they're sleeping and they'll wake up with a high BM as a result in the morning. So the management for hypoglycemia only is applicable if the Glasgow Coma Scale is 15 out of 15. So they're fully aware, fully conscious. And during that moment, you can give them Lucozade or an equivalent that you can find. or glucose shelf that's around, and a sandwich because that will give them a low, much slower release of glucose over time. You give them a finger prick glucose test every 1 to 2 hours until they're stable. So you're aiming for their blood glucose to be greater than 5 millimoles per liter. If after 2 hours this can't be achieved, call an ambulance. If there isn't an improvement in the patient's state, then you need to assess if this was deliberate or if it was an accident. Because if it was deliberate, then you need to get a psych consult and basically do safeguarding for that patient. Because if they go home or if they're by themselves, they might try to do it again. If they're in a coma or if they've got a low GCS, you call the ambulance, protect their airways just in case they vomit or anything like that by putting them in the recovery position and just wait for the ambulance to come. Thanks for listening. Are there any questions?
Questions at the end.
Oh, we can do the questions at the end.
Yeah, we can just do the questions.
Okay,
Do all the questions.
yeah, no problem then. Questions at the end then.
Yeah, it's makes it life very easy.
Perfect. So next up we have. Oh,
Put me on for hours.
Enggak, okay.
That's poison.
what did you want? Allergies.
Allergies.
My bad.
Appreciate it, Barry.
And here we have Paul.
Ta-da! Okay, so we're going to let me grab my pointer and everything, and yeah, we're going to talk through allergies. Okay, so this is just a quick overview of allergy. Allergies is the most chronic disease in all of Europe, and according to official statistics, the allergy prevalence in most countries is between about 10 and 40%. So Europe is on the high end, and the highest one in that is England. I believe actually it's 44%. So 44% of people in England report having some form of allergy. So in this presentation, we're going to cover the more severe end of allergies. Some people, if they eat a peanut, are going to get a very small localized reaction. They take some Piriton and they make sure they don't eat peanuts. That's fine, that's common, that happens all the time. This presentation is going to be going more into the sort of severe, sort of into anaphylaxis than this sort of very common garden allergies. We're also not going to be covering time or location specific allergies, because obviously another common allergy is allergy to anesthesia, which you're not going to be seeing anywhere, hopefully, or allergies to blood products. Those are two very separate, very specific situations that this presentation isn't going to cover. So signs and symptoms like this, these are the classic signs and symptoms, but these do cover some of the very, very mild symptoms. So obviously everyone knows urticaria. So you get that pronounced red, slightly raised rash, and it can be in the area or it can be more systemic. Like a lot of the times they'll get it on their trunk and on their neck seems to be the most common place, as well as wherever they got locally. If they have a form of like atopic dermatitis, they can get it more in the area and it spreads. Bronchospasms. So you can get bronchospasms. This is more into the severe end. So they'll be having difficulty in breathing. They'll feel like they can't catch their breath. Diarrhea and vomiting, DMV, is common in a lot of allergies because your body's innate reaction to try and, when it thinks it's got something extraneous, will be to try and purge itself. And the best way to purge itself is to push everything out. So DMV, obviously you get the flushing. So sometimes people don't get an urticarial rash. They will just become red and flushed. Abdominal pain, that's in with the DMV. It's how your body's going to force everything out. Itching is another very, very common one. You can get this with very, very mild reactions, or even for anaphylaxis, like itching is a very, very common. Like sometimes you don't even get a rash, they just start to feel sort of globally itchy. Wheezing, obviously bronchospasms, if you have severe enough bronchospasms, you will hear maybe a polyphonic wheeze. And obviously with swelling as well, it can be local to the area, or you can get the more severe forms, which are anything sort of angioedema, sort of any swelling around the eyes and any swelling of the tongue. Obviously, the tongue is is in your airway. So if you have a bronchospasm with a swollen tongue, that gives you a very high index of suspicion that you may have an airway emergency. So be advised. Here we go. Danger signs. Like you can have those signs and okay, they're going to probably need to go to hospital, but we're not driving it like we stole it. On the other hand, if they become hypotensive, this means they're having a massive inflammatory response. There is a very, very good chance that this person is already starting to peripherally dilate and this person is very unwell. This is very difficult to manage in most places except an A&E or an ICU. Low saturations, they've got a swollen tongue, they've got their bronchus is currently spasming. That means you will get the low saturations, an inability to move air. So the low sats and the chest tightness is obviously that kind of can be a bit of a precursor. So everything is starting to tighten up. So yeah, and stridor, obviously that's more airway. Like anaphylaxis is all airway, and circulation. So these are the danger signs. If somebody eats something and immediately sounds like they're starting to snore, you need to be very worried very quickly. Treatments, interventions, like adrenaline. These patients need adrenaline. They need intramuscular adrenaline. If they're known to have anaphylaxis, they may have an EpiPen with them. So if they have, get them to take it immediately. It's a 0.3 milligrams IM. If this person is taking something and has had a massive reaction, immediately their airway starting to swell, they may start to panic and may not be able to do it. You may have to do it for them. So if in doubt, just grab a muscle, grab the lateral side of their deltoid, jab it in and push the button. If you're not comfortable to do this, then you need to learn to be comfortable, to be honest, because you're going to save somebody's life doing that. I mean, worst case scenario, you just pull their shirt tight, stab it through their shirt, because this is a life-saving intervention, and this is a timed critical intervention. If they're say not in this state yet, they can take their auto injector. Also, do they have antihistamines or steroids with them? Some of them will. So advised to take max dose of both immediately, because you're taking a tablet, it's going to take time to work. And also, if they're getting swelling, they're going to, at one point, they may stop being able to swallow. So just get them to take it. Obviously, 999 as soon as you can. Position the patient appropriately. If they're having bronchospasms and starting to wheeze, get them sat upright, get them their chest expanded, get them as good as air entry, good air movement as you can. If on the other hand they're starting to lose consciousness, treat them as a shocked patient, get them down on the deck, get their legs raised. And another thing you may want to do is check for what's known as any potential constrictions. If they are starting to get peripheral edema, I mean, a watch is good, you can take it off. Wedding rings, on the other hand, in my clinical practice, I've cut off more than one wedding ring. So if this is happening, something you can do is check their fingers, check around their neck, look for anything, jewelry that you can take off now that might not have to be cut off later. So this is just something you can do, because you wore that wedding ring for 50 years, it may end up in 3 or 4 pieces. So this is a very, very serious situation to find yourself in. And it really sucks because there's not much you can do pre-hospitally, but early adrenaline. Like if you think they're having anaphylaxis, give them the adrenaline. because you're starting off a cascade that could potentially save their life. And that's everything from me. Thank you very much. I shall let Jean-Pierre.
Thanks, buddy. Okay. So my final presentation today will be on asthma emergencies. So we're not going to be covering just a normal asthma attack. We're just going to be covering the severe ones, the ones to really watch out for, and you will require assistance for. Okay, asthma emergencies. So we're going to be covering the background about what asthma is, and then we're going to be showing you how to use a peak flow meter and how to use an inhaler, because they're very common OSCE stations, and you're going to be having to show patients how to do it anyway. Severe asthmatic attacks, life-threatening, the features of both of them and what you should watch out for, the management of both cases, and when you're taking the history, key points to relay to physicians in terms of changing the regime that the patient might be on. So, asthma, it's a reversible airway bronchoconstriction. And basically, the reason why you can get it is a stimuli. It can be anything from dust to dog hair to cold weather to even just emotional state. So the multitude of factors that can stimulate an asthmatic attack are so vast that it needs to be controlled using bronchodilator. But the difference between asthma and, let's say, COPD is that when you take the peak flow reading, you'll find that there's an improvement of over 15% has to be of their peak flow reading after they take the bronchodilator, as opposed to an irreversible airway change like COPD, where you'll find no improvement. So reversible versus irreversible. You should be aware of both of these inhalers. If not, here they are. The blue one has salbutamol in it, the bronchodilator, which is used for the asthmatic attacks themselves. And the brown one, which is the actual, what I wouldn't call the treatment, but is the way to reduce the attacks, contains a corticosteroid. So we're going to discuss the uses of both of them, but just to recognize the two of them. When the person's having an asthmatic attack, do not give them the brown one because it will do absolutely nothing. The blue one is what they need when they're having an asthma attack. So just keep that in mind. So how to use an inhaler. So first things first, check it is not out of date. Sit the patient upright, like Paul said previously, so you have maximum lung capacity. Remove the mouthpiece cap. You take 2 deep breaths in and out. Oh, you can't see me, I'll demonstrate it in a second. You shake the inhaler, you then put it in your mouth and make sure there's a good seal around your lips and the mouthpiece. You breathe in slowly and deeply whilst pressing the inhaler button. And then you breathe, you hold your breath in for 10 seconds. If the attack hasn't gone away, you repeat the same process for after 30 seconds. You can do a maximum of 10 times. If you're using the brown inhaler, the steroid one, you have to wash out your mouth and then spit it out, because not only will it have problems with your dental hygiene, if you swallow that, it can increase the risk of having ulcers in your stomach. So that's why we recommend to patients, take the brown inhaler just before you brush your teeth in the morning, so you can wash it out afterwards. So just to demonstrate quickly what that kind of looks like. So I'm going to be using a Libro. So the whole idea is, so take 2 deep breaths in and out. Keep your breath out. Seal. normal practice when taking it. And I've lost the slide. There we go. Next, we'll be talking about peak flow. So this is basically the format they say for an auscultation. So you establish what the patient already knows about the peak flow meter, if they know what it is or not. You can see an example of what it looks like on the right top corner. You explain why it's important, because it's a way of assessing how well you're breathing. You connect a clean mouthpiece that you will find in a box somewhere. If you don't have a clean one, do not use the device, can't do it. And then it's your job to basically demonstrate to the patient first if they don't know how to do it. So same as the inhaler, you sit upright. Differently though, you take a deep breath in, you hold it, you wrap your lips around the mouthpiece that you've taken, that is yours, and then you breathe out as hard and fast as you can, like you're blowing out candles. And you repeat this 2 more times, and you write down the best out of 3, and that will be the peak flow. So to demonstrate it 1 time, because I'm not going to do it 3 times. Mouthpiece, sitting upright. As hard and as fast as you can. You do that 3 times, best out of 3, and you record it. Most patients that are asthmatics will know what their normal peak flow is. So if you do meet someone that's having an asthma attack, it's always good to ask them what their normal reading is, so you can compare it. Go. Okay. So a severe asthma emergency. The patient will not be able to complete full sentences. They'll be using their accessory muscles to help them breathe. They'll have prolonged expiration. Their heart rate will be over 110. If it's a child under the age of 5 years old, over 130, because children have naturally higher heart rates. Rest rate will be over 25. If it's a child under the age of 5, over 50, because children have a higher normal rest rate as well. And the peak flow reading will be 33 to 50% of the predicted. So that's based on the previous peak flow readings that they've done, which is important to take note of. Now, oopsie, go back one. So that's a severe asthma emergency, just to take note of it, because when we're moving on to the life-threatening one, the differences are quite similar, but pronounced. They'll only be able to say a few words or not be able to speak. Silent chest. So on auscultation, normally you hear like wheezing from a normal asthmatic, it'll just be silent. You won't be able to hear any breath sounds. Another complication that I haven't talked about in this lecture that they can have, if the gentleman is white, tall, and quite skinny, he might also have a spontaneous pneumothorax in this situation. So just to keep note, very, very serious things that are happening to this person right now. Cyanosis, clammy hands, high heart rate, confusion, agitation, and decreased level of consciousness. And the peak flow will be less than 33 of the predicted. So very, very serious scenario in this one. So if you can get them to, if they do have a level of consciousness, that's enough for you to go through the next steps I'm going to go through, do it. But if they're not conscious enough that they can follow any instruction, just call the ambulance straight away. Don't bother with anything else. Okay, so what you need to do when you find someone in this state. So commonly when I was playing rugby, kids that would have asthma attacks, we would take them into the building. And the reason for that is because usually you're playing rugby, it's very cold outside. One of the reasons why they probably got into the attack is the cold air. Simple as. So taking them inside to a warm environment can get rid of one of the triggers. Get them comfortable and upright to increase their lung capacity as well to help them breathe, and keep them calm. Because as previously discussed, your emotional state does play an important factor into your asthma attack. So by keeping them calm, you do help them a lot as well. You ask them to take their usual dose of their reliever inhaler, the blue one, not the brown one, and you ask them to take a puff every 30 to 60 seconds until they've had 10 puffs. If they're having difficulty taking the inhaler or they've got the wrong technique, now you know the right technique, so you can assist them while they're taking it so they can take it effectively. If the attack is severe or it's getting worse, call the ambulance straight away, because this is beyond your capabilities of what you have available to you to help this person. You monitor their breathing and their level of response. If the ambulance still hasn't arrived within 15 minutes, repeat step 3, which is taking the inhaler every 30 to 60 seconds up to 10 times. If they become unresponsive at any point, practice CPR on them. And yeah. Lastly, so in history taking of an asthmatic patient, so after they've had their attack usually, you would follow in the history of presenting complaint, MAILS IT, which is an acronym that we came up with to remember it. So their medication first. So how often are they taking their blue inhaler? That's the one that you're looking for, because that will establish their level of control. Because if they're taking their blue inhaler 5 times a day, that's not well-controlled asthma, not in the slightest. And basically also as well, their compliance. Are they taking the brown one in the morning? Because a lot of the time, people that are asthmatic patients, they'll take their blue one because that's the thing that helps them at the time. But because they don't know that the brown one is the one that's actually reducing the attack, they're like, I don't need to take this one in the morning. So it's just always good to keep note of that. ACP, history of any other hypersensitivity, like the disease they might have, like eczema, can also help, because it might mean that you might need to give them other medications, like prednisolone on top. Inpatient admissions is extremely important. The amount of time, if a patient says to you that they've been having 5 attacks a week, that's bad. If they've had to go to ITU once a year, that's the red flag that you need to say that this regime is really not working at all. We need to step them up a lot. Lifestyle factors as well. So how much work and how much school have you missed because of your asthma is the other important question to ask. Their symptoms are extremely important to differentiate between, is this asthma or is this something else? So for example, if they have a cough that is productive and they have like gray or yellow sputum as well, you're not thinking asthma in that situation. Or if they've got hemoptysis, you're not thinking asthma. You're thinking TB, or you're thinking pneumonia, things that could exacerbate the asthma, but that's a different treatment that that person needs at that point. So it's always good to ask what symptoms the person is going through. Interval timing. So is it exercise induced? Is it nocturnal? Because then it could be the type of sport they're doing or their emotional state during that sport. They might just have to cut the sport off altogether. And then I discussed previously triggers. Is it cold? Is it exercise? Is it pet? Is it smoking in the house? Because you can eliminate these, which will help the overall treatment of the patient. So these are just some of the things you look out for in the emergencies, identification of them, and history taking and why you do it. And on to Paul. You ready? There you go.
Me again. Back this time, we're going to be talking about poisoning. So poisoning is a condition in which an organism becomes damaged chemically by any sort of toxic substance. In this presentation, we're going to be covering systemic poisoning. So you won't find food poisoning in here because that's not a systemic thing, that's a one system. We also won't be finding localized poisoning like corrosions or anything like that. We will not be covering weaponized agents. That is a very big, very long presentation I can give. So I won't be talking about sarin, VX, nerve gas, mustard gas, any of those other, unfortunate tools of war. And I'm going to cover a lot of the more generalized, well, a few specific, but a lot more generalized poisoning. So in 2013, 2014, about 150,000 people were admitted to hospital with any form of poisoning. And like I said, most of the time it happens at home, and the highest risk factor are children under 5, because anything that's got like big letters on it, anything that's brightly colored, and they might just end up ingesting. Calpol is a prime one, because obviously Calpol tastes good, and when you're 3 or 4 years old, if it just tastes good, why don't you plug the whole bottle? So they have the highest risk of accidental poisoning. So, but 1 in 4 is a deliberate act, as they attempted to either hurt or kill themselves using with many methods. But it doesn't really matter. You kind of, your interventions will all be very similar. Hospital interventions different, but your management will be very similar. Okay, overdoses, both intentional and non-intentional, because not all overdoses are intentional. Lots of people occasionally, when they've got toothache, will take paracetamol and cocodamol. Obviously, cocodamol is codeine with paracetamol, and so potentially they've taken a double dose. So they have actually overdosed on paracetamol. So a lot of it is down to history. What have they taken? Have they taken not drugs? Doesn't matter what it is. What have they taken? Just get them to explain it to you. And also, what matters, what they've taken, is what have they taken it with. If they've taken a box of paracetamol and a bottle of bourbon, that you need to know that, because that changes management. Also, it changes their clinical presentation. This person who you know has taken an overdose of paracetamol also has a very low GCS. Maybe it's because they've taken other drugs and not told you, or it could be because of the alcohol. You need to know that they've ingested the alcohol. When did they take it? So if they took it 5 minutes ago, that changes the symptoms, and that changes what you could reasonably do to them in the coming hour or so. If they took it like 3 hours ago, you need to know that as well. Why? Was this an accident? Like, accidents do happen. Like the cocodamol and paracetamol, like that person probably took that accidentally. But if they've tried to hurt themselves, if this is a suicide attempt, you do need to know that, because it's also that you need to know this, and the people caring for this person need to know this going forwards. How much it does make a difference. Like, you can take 4 grams of paracetamol a day. If you've taken 5, okay, we don't need to worry. On the other hand, if you've taken 6 whole boxes, then you do need to worry. So you need to know how much they've taken and any other actions. If this was, say, a suicide attempt, and you start getting fixated on the overdose, but don't notice the fact they've also cut their wrists, or they've done something else, like, I don't know, maybe they sat in a pool of gasoline. Like, don't get task fixated. If somebody has tried, it's very common to attempt more than one type of suicide at once. Maybe they've taken an overdose and cut their wrists. That's not uncommon. But so don't get task fixated. Have you done anything else? Have you done anything to anybody else? You know, you need to know, like, in this state, what have you done? Okay, actions that you can take. One is secure the evidence. If they've drunk a bottle of Drano bleach, take the bottle with you, secure the bottle for many reasons. One of which is the hospital can use that because it has ingredients lists on the back, or if it's a specific brand, there are, in the America, they have the CDC. In the UK, we have a national poisons line, or ToxBase, that you can actually search down to brands. So take it on. So, and also, if it's a box of drugs, you can reasonably work out the maximum they have taken. If it's 20 paracetamol in a box and there's only 10 left, you know they have taken a maximum of 10. So secure this evidence. So people can use it going forwards. You know as well as I do that you can tell somebody something and it will get lost in whispers. You tell the paramedic tells the nurse tells the doctor, and it all becomes. But if you actually give them the box, that's that evidence. If this is a suicide attempt, secure the person. By that, I don't mean handcuff them. But if somebody tells you, look, I just took all these pills, a load of these pills to try and kill myself, it would not be prudent to, one, leave them in the room with the pills still. And also, if there's a very good chance, if once they've told you, the gravity may hit them and they may make a rash action, like I might head towards JP's balcony to think, I've just screwed my life up, oh no, and then one irrational thought, and 5 seconds later. So stay with the person. And obviously you call 999. If this person is actively trying to do something bad to themselves, calling 999 will bring the police as well, because the police can be sectioned, like, because, you know, maybe you may have to pin this person to the ground. You know, I can't advocate for that. You need to make the call. This is an unfortunate part of dealing with these situations, is sometimes you're going to have to make a call on the fly. And if it involves sitting on your friend to stop themselves trying to do a Klinsmann out of the 5th story window, you're going to have to make that call. It's shit, but it's the situation you're going to might find yourself in. Another one, this is another common one, is carbon monoxide. So carbon monoxide, obviously, the product of incomplete combustion. A lot of the time, it is due to faulty gas appliances. Like symptoms for carbon monoxide poisoning include shortness of breath and chest pain, nausea and vomiting, flu-like symptoms. These are all incredibly non-specific, as you can tell. The classic one is the flushed skin. A lot of the time you'll see it described as a cherry red face. That doesn't happen so often, but they may have sort of reddening of the face. This can also happen with smoke. Anyone who's involved in a house fire, you must have a high index of suspicion for not only for smoke inhalation, but for carbon monoxide poisoning and also cyanide poisoning. Because what a lot of people don't realize is your fireproof furniture is only fireproof to a point. Once it ignites, what comes out is essentially, you know, aerosolized cyanide. So be careful for that. Anyone involved in house fires and management there is a completely different topic. So you see these symptoms. It's very basic. What you can do is, one, you remove the patient. Now, you're unlikely to be overwhelmed by carbon monoxide unless you live there, because carbon monoxide's half-life is long. You can spend 12 hours a day in there, leave for 12 hours, come back, and you've not gone back to normal. And over time, you get to the point where it may take you down. Or if you have a high flow gas, like a mains boiler that has critically failed, but then you're talking hours and hours and hours of prolonged exposure. Now, if you can't remove the patient, if you're in Canada, up on the prairies, it's -50 outside, get all of the windows open, ventilate as best you can, call 999, and the immediate action that you can take if a community first responder turns up is get a non-rebreathe mask, the face mask with the bag underneath, inflate the bag, get it up as high as it can, as much flow, and strap it to their face as tightly as possible. You're destroying the half-life of the carbon monoxide and you'll get it out of their system. Some people are quite resistant to carbon monoxide. If you smoke, your carbon monoxide is probably level naturally is probably half or probably twice what mine is, or if you live in a city. That's about as much as you can do. Get to hospital, they may need advanced airway management. And in fact, if it's very bad, they may need a hyperbaric chamber, of which I believe in the UK there's 3. But carbon monoxide, thing to do is to recognize it might be carbon monoxide and get them out. If you can't get them out, it's probably going to be fine, but you need to make sure that people know down the road that you suspect it was carbon monoxide. Because last thing you want is them to think, oh, he just fainted at home, and send him home again, back to his carbon monoxide flat. Okay, organophosphates. These are industrial pesticides, mostly used in industry and mass farming, like mass agriculture. Presentations of these are all very, organophosphates are the most common type of poisoning when it comes to these sorts of chemicals. Like the presentation of the patient is quite an easy one, like mild, moderate, severe. Can they walk? Yes, that's probably mild. If they're breathing properly, but they're unable to get up, like maybe they're unconscious but breathing normally, maybe they just can't walk because they're too dizzy, that's probably moderate. If you've got them apneic or agonally breathing, then they're very, 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 very unwell. The likelihood is you may have to do CPR on them. So obviously, they start with the clinical symptoms. Organophosphates start on the muscarinic system. So you get lacrimation, salivation, blurred vision, meiosis, all of these, because it's knocking off those neuroreceptors. So you get the abdominal pain and the bradycardia. Another one, if you find an unconscious person who's bradycardic, you have to think about chemical exposure. Obviously, moving into moderate, they can have those plus dyspnea, wheeze. Obviously, they're in a much worse state, so they can have diarrhea, incontinence, because their neurological system is eventually being overloaded to the point where you end up with nicotinic symptoms, which is respiratory failure. Like you have what they call the killer bees. You've got bronchorrhea and bronchospasms. Bronchorrhea is basically secretions in the films. Do you know when you see people they get exposed to gas and all the secretions start? It's not that quick, but it is like that. People can end up drowning in their own secretions, and you get flaccid paralysis, seizures. These people are incredibly, incredibly unwell, and you need to do whatever you can, which may well be absolutely nothing. So organophosphates are in the same group as nerve agents, sarin, things like that. Weaponized forms of organophosphates they are weaponized. Like this is what you think of as nerve agents. Like it starts with the muscarinic symptoms, moving to the nicotinic symptoms. So basically, it stops your body's ability to produce acetylcholine. So in the synaptic cleft, those neurotransmitters do not go away, and essentially it opens up overloading itself. So treatment, my first thought is extreme caution. This stuff can overwhelm you in seconds. You may well walk into a room, see somebody laying down and start to feel really weird. Like we're talking seconds. Like if you feel that, you might want to just backpedal, because this stuff doesn't go away very quickly. You may end up being a patient yourself. This as a vapor, and even the liquid itself is incredibly dangerous. Like if you go in there, you see it, you suspect it, you're gonna wanna you're gonna be in a crappy situation, because you may have seconds before you go down yourself. So like I said, call 999, tell them what you are suspecting, because they will need the HARP team, which is the Hazardous Area Response Team from an ambulance service. You may also need the specialist units from fire brigades here. This stuff is incredibly dangerous. That's why it's used as a weapon. If you're in the area and you suspect, you see somebody down, you may have to do what's called a snatch extraction. Grab a body part and start pulling. They've got injuries. You pay your money, you take your chances. This person may well be dead very soon, and you may well be following them. So just if you can get them out there, great. If you can't, don't risk yourself, because otherwise you're going to be casualty number 2. And if it's not that bad, if they've been exposed over a long period of time and you're okay in there, drag them out. And if you think it's organophosphates, you may well have to stay away from them. Like they say, you can in theory remove clothes. If they've got a big outer layer on, get those off them, because they are still getting the vapors. This, like I said, This is quite rare, but this is also incredibly dangerous. Now onto something not quite so dangerous for you, opioids. So I'm not going to go into all of the recreational drugs because essentially a lot of it is symptomatic management. If somebody's just snorted an 8-ball of Coke, you manage them as probably a psychotic patient, to be honest. If they've taken a load of ketamine, you manage them as an unconscious patient. It's a very big, broad topic, but the ones that you can do the most about opioids, whether or not it's prescription opioids, aka methadone, OxyContin, whatever, or they've just shot a load of heroin, the presentation and treatment are the same. You'll see them like pinpoint pupils are the classic. You open their eyes up and they are literally pinpoints. So in some cases, they're literally just black dots. They'll have a low GCS, and the worst part of it is the decreased respiration. Obviously, the opiates are going to hit the breathing center. They may only be breathing 6 times a minute. So your initial treatment is airway management. These people have got no airway reflexes. If they vomit, they're going to aspirate. So get them onto their side. It says that stimulate the patient, give them a good hard shake. That might wake them up and they may start breathing again. They may stop breathing again, back down to 6. 10 seconds later, you're just going to have to keep repeating it. You call 999 because this person is going to need naloxone. You can give them 400 micrograms intramuscularly, and in about 5 minutes, they're going to be sitting up asking you what happened. Some police services carry naloxone, especially up in the northeast of England, where opiates are unfortunately quite prevalent. So if the police are there, ask them, do you have naloxone or Narcan or anything like that that we can give to try and keep this person breathing? Another very, very common one is alcohol. So it's a leading cause of poisoning in England, especially amongst young people, because we all like to go out and get a bit wasted occasionally. Well, you do. I'm too old now. I'm just a young man's game. So obviously the symptoms of somebody who's heavily intoxicated, they're confused, they've got slurred speech, no coordination, they may be vomiting, they can have slow or irregular breathing, especially if they're very, very, very drunk. They can have hypothermia, and they can also have hypoglycemia as well, which can, especially if you're diabetic, or sometimes if you've just not eaten, like you can end up hypoglycemic and drunk at the same time. So you have to be careful with that, especially if you find out that they be diabetic. And you can have them unconscious or in a stupor. So obviously stupor is they appear awake, their eyes are open, but they are just not moving. They're just in an alcoholic stupor. So what you can do is you're trying to sit them up and keep them awake, because obviously alcohol, vomiting, decreased airway reflexes, you do not want them to aspirate. You can give them water. Like, it's probably not going to sober them up a great deal, but they may thank you in the morning, as they might be slightly less hungover and dehydrated. Obviously, if they're unconscious, you manage them as an unconscious patient. You need to keep them warm because they're at high risk of hypothermia, because they are incredibly relaxed. They're not generating much heat from their muscles, so they can get hypothermic, especially if they've been passed out outside, because it suppresses their shivering reflex as well. So they can. And 999 if you are concerned. If you're concerned or you're not, I'm not sure, do it. I've been an A&E nurse for over a decade. I have a lot of clinical experience. I would know if I needed to call an ambulance or not. I can't teach you my 10,000 plus patients that I've worked with. So if you're in doubt, call the ambulance. You're going to get some moaning from paramedics, moaning from hospital staff, but it's better that than something bad happened. So 999 if you're concerned. Any questions? Unless there's any questions for anything, because this is the last bit. So I'm going to bring in John Pierre.
Oh, you share this? Oh.
Yeah, we can share it. And yeah, that's me and my Teletubbies. Shall we stop sharing? Yeah, okay, so we're here now. Have we got any questions, Bilal? As you're the head chef, big cheese, in charge of all these stuff. Okay. Are we doing it through the chat thing? Let me open all the chat stuff up then. Okay. Blah blah blah. How do you expect? Check the ketone levels.
How to check the ketone levels?
Oh, I'll let you do it. It's your bag.
Oh, thank you.
It's your bag.
Easiest way to check for it in any patient is urine dip. Fastest, quickest way to do it is urine dip. That's it. Well, yeah, the finger prick, you can use it as well, but you have to make sure that person has the right one for it. But most diabetic patients will have the ketone one as well.
Yeah. So these days, a lot of them on the, if they've got meters, will have strips for blood glucose and strips for ketones, and you can just plug one in. So you can do it with urine, but if they've got a ketone meter, just do it like a finger prick, like blood glucose, and you will get a ketone reading.
Yeah.
A capillary ketone reading, which will give you, which is why it's not the most accurate thing in the world.
False positive, but still better.
It's all you've got.
Mm.
How do you treat patients with lithium and self-harm? Well, lithium batteries. First thing, you can't ultimately treat them pre-hospitally. You get them in and you x-ray them. You can x-ray because obviously you've got a metal bead here, because you need to x-ray them very quickly because lithium batteries are very corrosive. And especially if they're in the stomach, it's not so bad. If they are lodged in if they are lodged in the esophagus or anywhere, they will start to corrode. So a chest x-ray immediately, and then a lot of the time, especially if it's a fair way down, it's time to go to upper endoscopy, intubate them, upper endoscopy, and your GI guy is going down in there to remove it.
I think if it actually does tear, they have to do laparoscopy, right?
Very unlikely. These batteries are incredibly solid. Like if it's torn, on the other hand, then that's a surgical emergency. Upper GI are taking them straight to theatre.
Yeah.
But what you can do is think, if they've taken it, is you need to get them to hospital quick for that chest x-ray. So once they've had the chest x-ray, they know where it is. That's basically what you need to do is early recognition and get them to the hospital as quickly as possible, and just make sure you hand this stuff over. Not that they've swallowed something, they've swallowed a lithium ion battery, one of these big round ones. Those are the ones that cause the most damage. This is you, asthma.
What to do if someone has an asthma attack that doesn't have an inhaler? So in that situation, literally get rid of the triggers. You just have to get rid of all the triggers you can. Keep them as calm as possible. Try and find an inhaler from someone around as quickly as possible.
It may just be a case of, especially if it's a first asthma attack, ambulance.
Yeah,
because one, you're going to have a lot of sympathetic drive here. This person, it's not very nice when you can't breathe, especially if they've never experienced it before. They may be so panicked that you cannot, you're just going to have to call an ambulance and get them to take them to hospital. So if they haven't got, or maybe they don't have their inhaler with them, ambulance. The worst case scenario is, or the best case scenario is, the paramedics may turn up, give them a couple of nebs, and they're absolutely fine.
Yeah.
And then that's it. They don't take them to hospital. But if it's a breathing issue, just because you call an ambulance doesn't mean they have to go to hospital. But it's
they have what you don't have.
Yes, exactly. They have oxygen, drugs, and the ability to drive this person to hospital if it all goes a bit sideways. Are there any more questions? Yeah, watching. Wait to see if it pops up. Nothing.
No, I think that was all the questions.
Okay.
But yeah, so thanks, Paul and JP. It was great stuff. It was really informative. This session is being recorded and will be uploaded onto our YouTube channel sometime in the week. We'll also send out an informative summary of all the points that were made today. So yeah, join us next week when we'll have our last session for the emergency workshops. And thank you all for joining. Stay safe.